Welcome back to our continuing journey through Step 2. In this lesson, we shift our focus to nuclear imaging and its indispensable role in diagnosing transthyretin cardiac amyloidosis. One of the key clinical challenges lies in differentiating ATTR-CM from light chain cardiac amyloidosis, or AL amyloidosis. While ATTR arises from misfolded transthyretin protein, AL amyloidosis is due to misfolded immunoglobulin light chains produced by plasma cells in conditions like multiple myeloma. This subtype is more aggressive and requires urgent hematologic evaluation and therapy. What complicates matters is the fact that both AL and ATTR amyloidosis share overlapping imaging and clinical features, making accurate diagnosis essential since their treatment pathways are entirely different. This is where nuclear imaging steps in. Now let's take a closer look at the imaging techniques commonly used in the evaluation of cardiac amyloidosis. A range of imaging modalities is available, each offering unique insights and diagnostic strengths. One of the most widely accessible is planar scintigraphy using technetium-labeled radiotracers. This technique plays a central role in the non-invasive diagnosis of transthyretin cardiac amyloidosis. Planar images are typically acquired 1 hour after tracer injection and interpreted using the Perugini grading system, which classifies myocardial tracer retention in comparison to rib uptake, ranging from grade 0 to grade 3. This image visually compares the two primary interpretation strategies commonly used in clinical practice for 99-MTC-PYP imaging in the diagnosis of transthyretin cardiac amyloidosis. On the left panel, we see the quantitative approach, which uses the heart-to-contralateral lung, or HCL, ratio. On the right panel, we have the semi-quantitative Perugini visual grading system. So why does this matter? Accurate diagnosis of a ATTR-CM using circumflex 99 MTC-labeled bone-seeking radiotracers like PYP depends on two key components: following standardized acquisition protocols and applying a structured interpretive framework. Positron emission tomography, computed tomography, or PET-CT, is another advanced modality used in selected settings. PET imaging employs tracers that bind directly to amyloid fibrils, such as 18F-fluorbetabine, 18F-fluorbetabine, or 11C-Pittsburgh compound B. These tracers offer quantitative analysis and whole-body imaging potential. However, PET is less widely available and, importantly, its ability to distinguish between ATTR and AL amyloidosis is still under investigation. Finally, 123I-methiodobenzyl-guanidine imaging, or 123I-MIBG, evaluates cardiac sympathetic innervation. While promising for detecting early dysfunction, MIBG remains largely confined to research settings and is not yet part of routine clinical evaluation for amyloidosis. Together, these imaging tools provide a powerful, multimodal approach to identifying and characterizing cardiac amyloidosis, especially when used in combination with laboratory testing and clinical assessment. Now let's summarize the key characteristics of nuclear imaging modalities used in the evaluation of cardiac amyloidosis. First, bone scintigraphy. This method uses technetium-labeled tracers, specifically 99-MTC-PYP, DPD, and HMDP. It's capable of detecting only ATTR amyloidosis and only when monoclonal protein screening is negative. Quantification is available through the heart-to-contralateral lung ratio and Perugini visual grading. While whole-body imaging is partial with DPD and HMDP tracers, bone scintigraphy offers high specificity for diagnosing ATTR-CM and is widely available. However, there are limitations. False positives can occur in AL cardiac amyloidosis, and equivocal grade 1 results often require confirmatory biopsy. Next, PET-CT. This modality utilizes tracers like 18F-fluorbetabine, 18F-flutemetamol, and 11C-Pittsburgh compound B. It can detect both ATTR and AL subtypes and allows for quantitative analysis using SUV and retention indices. Importantly, PET-CT offers whole-body imaging capabilities, providing high spatial resolution, detection of early-stage disease, and systemic amyloid mapping. Its limitations include high cost, limited availability, and a lack of subtype specificity. Also, standards are still evolving, making its role in routine diagnosis less established. Finally, 123 IMIBG scintigraphy. This technique evaluates cardiac autonomic innervation, particularly in hereditary ATTR cases. It does not directly visualize amyloid, but instead measures a heart-to-mediastinum ratio to infer denervation. Unlike the other modalities, it does not support whole-body imaging. Its strength lies in assessing autonomic involvement in variant ATTR. However, its diagnostic role is limited. Results can be influenced by ischemia, and the technique is not amyloid-specific. Now that we've established the critical role of nuclear imaging in diagnosing transthyretin cardiac amyloidosis, let's turn our focus to how these studies are actually performed, step by step. Standardized imaging techniques are essential for achieving reliable, reproducible, and clinically meaningful results. International guidelines, particularly those from the American Society of Nuclear Cardiology, ASNC, have outlined precise protocols to optimize both the acquisition and interpretation of radionuclide imaging using technetium-labeled tracers like 99-MTC-PYP, 99-MTC-DPD, and 99-MTC-HMDP. These protocols guide us through 4 key steps: visual interpretation of planar and SPECT images, semi-quantitative grading using the Perugini visual score, quantitative analysis through the heart-to-contralateral lung ratio, and advanced pixel-based quantification to assess disease burden. Following these steps systematically ensures not only accurate diagnosis of ATTR-CM, but also the ability to distinguish it from potential mimics, such as blood pool activity, infarction, or even overlapping bone structures. We'll walk through each step in detail, highlighting technical requirements, interpretive strategies, and diagnostic thresholds, all based on current best practices and evidence-based consensus guidelines. Let's begin with Step 1, Visual Interpretation. Step 1, Visual Interpretation. To begin the interpretive process, the initial step in evaluating 99-MTC-labeled bone scintigraphy is the visual review of both planar and SPECT images. According to guidelines from Dobala et al. 2019, it is essential to assess both modalities in tandem. This dual assessment increases diagnostic precision by allowing clinicians to confirm diffuse myocardial tracer retention and exclude potential confounders, such as persistent blood pool activity, prior infarction zones, or overlapping bone signals like rib fractures. One key consideration is timing. If the initial 1-hour scan shows ambiguous uptake that could be due to circulating tracer in the cardiac chambers, a delayed acquisition at 3 hours is recommended to improve specificity and clarity. The lower panel visually demonstrates this principle. Here, SPECT imaging is shown to refine the diagnostic picture by clearly differentiating myocardial uptake from surrounding structures. This refinement is crucial, especially when the planar scan presents borderline or indeterminate findings. Once diffuse myocardial uptake is confirmed visually, the next step is to move on to semi-quantitative grading using the Perugini system. Step 2. Semi-quantitative grading Perugini visual score. Once myocardial uptake is confirmed on visual inspection, the next step is semi-quantitative grading using the Perugini visual scoring system. This is currently the most widely accepted framework for evaluating radiotracer retention on planar imaging when using 99 MTC-labeled agents such as PYP, DPD, or HMDP. Here's how the grading works. Grade 0, no myocardial uptake with normal bone uptake. Grade 1, myocardial uptake is present but less than the rib uptake. This is considered equivocal. Grade 2, myocardial uptake is equal to the rib uptake. This is suggestive of transthyretin cardiac amyloidosis. Grade 3, myocardial uptake is greater than rib uptake, and the ribs may appear faint or absent. This strongly supports a diagnosis of ATTR-CM. These gradations are visualized in this figure, which includes anterior planar chest images, SPECT cardiac images, and whole-body planar images. Each modality captures the progressive myocardial tracer retention from grade 0 through grade 3. In practice, when a patient presents with grade 2 or grade 3 uptake and there's no evidence of monoclonal gammopathy, this combination is diagnostic for a ATTR-CM. On the other hand, equivocal findings, particularly grade 1, do not confirm the diagnosis. These cases require histological confirmation, typically through endomyocardial or abdominal fat pad biopsy. Step 3, quantitative interpretation, heart-to-contralateral or HCL ratio. When visual grading results are equivocal, particularly in cases that fall into grade 1 on the Perugini scale, a quantitative approach can significantly improve diagnostic clarity. This is where the heart-to-contralateral lung, or HCL ratio, becomes a vital adjunct in evaluating planar bone scintigraphy. The HCL ratio offers a standardized pixel-based method to quantify myocardial tracer retention using 99 MTC-labeled radiotracers like pyrophosphate, PYP, DPD, and HMDP. This technique is especially effective in borderline cases or when clinical suspicion remains high despite inconclusive imaging. Let's walk through the methodology. First, a region of interest, or ROI, is drawn over the heart on anterior planar images. These images are typically obtained around 1 hour after tracer injection. Next, an identical ROI is mirrored onto the contralateral chest wall. It's critical to avoid including the ribs, sternum, lung base, or right ventricle to ensure accuracy. Both ROIs must be positioned above the diaphragm to minimize interference and maintain proper background subtraction. Finally, the HCL ratio is calculated by dividing the mean counts per pixel in the heart, ROI, by the mean counts in the contralateral ROI. Now let's talk about interpretive thresholds. An HCL ratio of 1.5 or greater at 1 hour post-injection is considered diagnostic for ATTR-CM, but only if SPECT confirms myocardial uptake and AL amyloidosis has been excluded. For imaging performed at 3 hours using DPD or HMDP, a threshold of 1.3 or greater is supportive of an ATTR-CM diagnosis. It's important to emphasize that HCL quantification should not be used when myocardial uptake is not confirmed on SPECT. And when visual grading already indicates grade 2 or 3 uptake, this quantitative step is often unnecessary, provided monoclonal gammopathy has been ruled out. Figure 6 demonstrates this clearly. In panel A, both heart and contralateral ROIs show similar count densities, indicating a negative scan. In contrast, panel B shows significantly higher myocardial counts, supporting a positive diagnosis. These images also display the numerical output, total counts, mean counts per pixel, standard deviation, all of which offer a deeper level of confidence in scan interpretation. Now let's briefly compare this with 99 MTC DPD imaging. Unlike PYP, DPD imaging often includes whole-body scanning, using a dose of 25 to 30 MCI and about 200 minutes of study time. Here, ratios are generated using ROIs over the heart, with background references drawn over the kidneys and bladder. Ultimately, quantitative methods like the HCL ratio provide a reproducible and objective bridge between visual grading and advanced molecular imaging techniques such as PT. They not only enhance diagnostic precision, but also support consistent decision-making across imaging centers in clinical nuclear cardiology. Step 4, advanced pixel-based quantification. Now that we've covered visual grading and HCL ratio interpretation, let's look at a more refined approach, pixel-based quantification. This method takes diagnostic precision a step further by examining radiotracer uptake at the pixel level. Here, we're not just visually estimating uptake or comparing regions. We're using software to measure exact values, providing objective, reproducible data to support or clarify visual findings. Specifically, 3 key metrics are evaluated. Mean counts per pixel, which reflects the average radiotracer concentration within a defined region. Total ROI counts, which sum all pixel values in the region of interest, giving a measure of total tracer accumulation. Area of myocardial versus background ROI, which ensures standardized comparisons across scans. Higher differences in these counts, especially when myocardial uptake clearly exceeds background regions, strongly support the presence of ATTR-CM. This technique is especially helpful when the scan findings are equivocal or fall near diagnostic thresholds. By applying pixel-based quantification, clinicians gain another layer of diagnostic confidence, bridging the gap between visual assessment and quantitative molecular imaging tools like PET. Let's now bring everything together through an integrated clinical workflow. The on-screen figure illustrates the diagnostic pathway endorsed by the European Society of Cardiology and the American Heart Association. When evaluating a patient for suspected transthyretin cardiac amyloidosis, the primary diagnostic approach begins with two parallel tests: bone scintigraphy using Perugini grading and comprehensive monoclonal protein screening. This dual strategy forms the cornerstone of current diagnostic algorithms recommended by the European Society of Cardiology and other major societies. Let's explore the decision pathway step by step. If bone scintigraphy reveals grade 0 myocardial uptake and monoclonal protein testing is negative, a TTR-CM is considered highly unlikely. No further amyloid-specific testing is required in most cases. However, if the scan shows grade 1 uptake, the findings are equivocal. In such situations, the next step is clear. The patient should undergo endomyocardial biopsy to confirm or rule out cardiac amyloidosis. When the scintigraphy shows grade 2 or grade 3 myocardial uptake and monoclonal protein screening is negative, this combination is diagnostic of ATTR-CM. At this point, TTR gene sequencing is essential to distinguish between the wild-type form and the hereditary variant. Now let's consider more complex scenarios. If the patient shows grade 0 uptake on scintigraphy but tests positive for monoclonal proteins, amyloidosis is still possible, just not ATTR. In these cases, cardiac MRI or biopsy is recommended to explore the possibility of AL or other forms of amyloidosis. In select cases, a strongly suggestive cardiac MRI paired with a positive extracardiac biopsy, for example from fat pad or salivary gland, may confirm a systemic amyloidosis diagnosis without the need for nuclear scintigraphy. It's worth emphasizing, monoclonal protein testing is mandatory in all cases of suspected cardiac amyloidosis. This includes serum and urine immunofixation as well as the serum free light chain assay. Finally, whenever monoclonal proteins are present, imaging alone cannot confirm a TTR-CM. A biopsy with mass spectrometry-based typing is required to exclude AL amyloidosis before any diagnosis of ATTR-CM is made. Now let's talk about how these diagnostic principles apply in real-world clinical settings. Today, nuclear imaging has become an integral part of the standard diagnostic workup for suspected ATTR cardiac amyloidosis, especially in patients over the age of 60 who present with heart failure with preserved ejection fraction, unexplained left ventricular hypertrophy, or red flag signs like bilateral carpal tunnel syndrome or a history of spinal stenosis. In these patients, the presence of grade 2 or 3 myocardial uptake on technetium-labeled bone scintigraphy, such as 99-MT-CPYP, DPD or HMDP, in the absence of monoclonal protein, is diagnostic for ATTR-CM. No biopsy is needed in such cases, and the diagnosis can be confidently established using non-invasive methods. This multimodal, stepwise approach, starting with clinical suspicion, followed by imaging and laboratory testing, helps minimize diagnostic delays. Most importantly, it enables the timely initiation of disease-modifying therapies, which is essential for improving long-term outcomes in patients with transthyretin cardiac amyloidosis. By embedding these protocols into routine clinical workflows, we move closer to a healthcare model that is proactive, precise, and patient-centered. Now let's look ahead at the future of imaging in cardiac amyloidosis. Continued innovation in nuclear imaging is transforming the landscape, with a focus on enhancing diagnostic specificity, improving quantification accuracy, and expanding clinical utility. Researchers and clinicians alike are working to ensure that imaging plays not just a diagnostic role, but an active one throughout the patient journey. One exciting area of advancement is in radiotracer development. Novel compounds like fluocinolone are being clinically evaluated for cardiac amyloid imaging. These tracers are engineered for higher binding affinity, longer half-lives, and better image contrast, offering distinct advantages over earlier agents like 11C-Pittsburgh compound B or 11C-PIB. In parallel, new 18F-labeled tracers, adapted from Alzheimer's disease research, are being trialled for cardiac use, with the aim of delivering cardiac-specific protocols in a more clinically practical format. At the same time, artificial intelligence (AI) is emerging as a powerful tool in this field. AI-assisted platforms are being developed to help automate segmentation, quantify uptake, and interpret scan results with greater precision. These systems promise to enhance diagnostic reproducibility, reduce inter-reader variability, and enable earlier detection of myocardial amyloid, especially in subtle or borderline cases. There's also growing interest in hybrid imaging, specifically PET-MRI. By combining the molecular sensitivity of PET with the anatomical and tissue characterization strengths of MRI, PET-MRI provides a rich dual-layered view of the heart. This includes insights into myocardial structure, extracellular volume, and amyloid burden, which together may enhance disease staging and allow for more nuanced treatment monitoring. Additionally, whole-body amyloid imaging using PET-CT is being explored. This technique maps systemic amyloid deposition, not just in the heart but across organs, which is especially useful for tailoring management in multi-organ amyloidosis. And as disease-modifying therapies become more widely available, nuclear imaging is being reimagined as a monitoring tool, not just a diagnostic one. Quantitative PET parameters, such as the standardized uptake value, SUV, and retention index, may serve as biomarkers of treatment response, enabling clinicians to assess efficacy and adjust therapies with greater confidence. Taken together, these innovations are guiding us toward a future where nuclear imaging is more precise, informative, and integrated, not only helping us detect disease, but actively shaping how we treat it. Now let's turn to real clinical examples that show how nuclear imaging, combined with biochemical testing, plays a crucial role in diagnosing transthyretin cardiac amyloidosis. These case studies highlight how appropriate integration of modalities can confirm or clarify even complex cases, often sparing patients from invasive procedures. Let's go through two real-life cases with Dr. Mary.
Hello everyone, let's start with case 1, AL cardiac amyloidosis, mimicking a TTR in a patient with V122I mutation, a 56-year-old African-American male. This patient had a known V122I transthyretin or TTR gene mutation. He presented with symptoms of heart failure. His echocardiogram revealed concentric left ventricular hypertrophy and a preserved ejection fraction, classic findings that raise suspicion for cardiac amyloidosis. Given his genetic profile and the echocardiographic pattern, the initial clinical impressions strongly lean toward transthyretin cardiac amyloidosis. To further investigate, the clinical team proceeded with planar bone scintigraphy using technetium-99M pyrophosphate, commonly referred to as 99-MTC-PYP. The scan revealed grade 1 myocardial uptake. This means the intensity of tracer accumulation in the myocardium was less than that in the ribs, an equivocal result according to the Perugini grading system. In other words, the scan was neither clearly positive nor clearly negative for a ATTR-CM. Recognizing the need for clarity, the next step involved biochemical testing. Serum and urine immunofixation electrophoresis, along with a serum-free light chain assay, were performed. These tests came back positive for a monoclonal lambda light chain clone, suggesting the possibility of AL amyloidosis rather than ATTR. To confirm the diagnosis, an endomyocardial biopsy was performed. Tissue samples were subjected to mass spectrometry-based amyloid typing. The result? lambda light chain amyloid, confirming AL cardiac amyloidosis or AL-CM. But the workup didn't stop there. The team proceeded with advanced molecular imaging using 18 of fluorobutapyr PET-CT. On partial body PET images, there was intense tracer uptake not only in the myocardium but also in the parotid glands. A transverse fusion PET-CT slice clearly demonstrated diffuse radiotracer retention within the myocardial tissue, consistent with extensive amyloid infiltration. Based on these findings, the patient was started on a targeted chemotherapy regimen consisting of bortezomib, cyclophosphamide, and dexamethasone. He subsequently achieved a complete hematological response. This case offers two critical teaching points. First, it highlights the indispensable role of monoclonal protein testing. Even when imaging findings might suggest a ATTR-CM, a positive result for monoclonal light chains demands further evaluation for AL amyloidosis. In such cases, imaging alone is not enough. Second, it showcases the added diagnostic value of PET-CT with amyloid-binding tracers like 18F-fluorobutapyr. In this scenario, PET-CT successfully detected significant myocardial amyloid burden, even when the 99 MTCPYP scan had shown only grade 1 uptake. In summary, this case underscores the need for a thorough, multimodal diagnostic approach. It demonstrates how genetic, biochemical, and advanced imaging tools work together to distinguish between ATTR-CM and AL-CM, two diseases that may look similar but require fundamentally different treatments. This next case explores the evolving role of hybrid molecular imaging in the ongoing management of hereditary transthyretin cardiac amyloidosis. The patient in question had a confirmed diagnosis of a TTR-CA and coexisting polyneuropathy. He was already receiving tafamidis therapy, which is the standard disease-modifying treatment for transthyretin amyloidosis. Despite treatment, the patient presented with new-onset dyspnea, raising concerns about possible disease progression. Cardiac MRI was the first step in the imaging workup. T1 mapping revealed a significant prolongation in relaxation time, indicating diffuse myocardial involvement. Subendocardial late gadolinium enhancement, or LGE, was also observed, further confirming amyloid infiltration of the myocardium. To gain additional insights, clinicians turned to hybrid imaging with 18F-flutemetamol PET MRI. This tracer, originally developed for detecting cerebral amyloid in Alzheimer's disease, has shown promise in cardiac applications as well. The PET images revealed diffuse radiotracer uptake in both ventricles, consistent with widespread cardiac amyloid deposition. These findings, combined with the MRI-based structural changes, pointed toward advanced stage disease progression, despite the patient being on active therapy. This case is a powerful example of how PET MRI fusion imaging can add clinical value, not only in diagnosis, but also in monitoring disease activity over time. For patients with hereditary ATTR undergoing treatment, subtle progression may not always be detectable by symptoms or standard tests alone. But with integrated molecular and anatomic imaging, clinicians can detect and quantify even early or subclinical changes. In summary, this case illustrates the emerging utility of hybrid 18F-flutemetamol PET MRI as a comprehensive tool for evaluating disease burden, therapy response, and progression in a TTR-CA. It reinforces the need for precision imaging and personalizing care for amyloidosis patients. In Case 1, the diagnostic algorithm proved crucial in supporting a non-invasive diagnosis of transthyretin cardiac amyloidosis. The patient presented with a Perugini grade 2 uptake on scintigraphy, and monoclonal protein testing was negative. This combination, according to current ESC and AHA guidelines, was sufficient to confirm ATTR-CM without the need for biopsy. This early and non-invasive diagnosis enabled prompt initiation of therapy and allowed for subsequent transthyretin genotyping to distinguish between wild-type and variant ATTR. In contrast, Case 2 involved a patient with hereditary ATTR-CM under active treatment who developed worsening symptoms. Despite being on tafamidis, the patient's PET MRI imaging with 18F-flutemetamol revealed diffuse myocardial tracer uptake, indicating persistent or progressing amyloid deposition. This advanced hybrid modality provided a level of diagnostic sensitivity that conventional techniques might have missed, highlighting the importance of modern imaging tools in disease monitoring and post-diagnostic surveillance.
Thanks, Dr. Mary. Together, these cases emphasize the strength of integrated diagnostic pathways, combining nuclear imaging, serologic evaluation, histologic confirmation when necessary, and genetic testing. Such a comprehensive, algorithm-driven approach not only enhances diagnostic accuracy, but also improves the timing of treatment and facilitates individualized patient care over time. In Module 4, we will explore how to apply nuclear imaging results within standardized diagnostic algorithms, integrating laboratory findings and clinical features to accurately diagnose and classify cardiac amyloidosis.